wants or wishes in that. It's one of the main goals. I think here there's some history. So the criteria here: irreversible cessation of circulatory and respiratory function, and irreversible cessation of all functions of the entire brain. Now, I wonder if this is the most updated. I'm sure this presentation will go forward in time too.
Oh, let's see prerequisites. So I think when I was reading the Continuum article, there was an AAN consensus guideline in 2010, and then there was Society of Pediatrics in 2011. Oh, this is my Vedix. He's one of my neuro ICU consultants. This was published in what year? 2010. So this
is this the one?
Yeah. Yeah, this is the one that the Continuum article quotes. Nice. Can you send? I'm gonna pull up that article and put that in my note. Yeah.
Yeah.
Cool.
For sure. Let me open the Continuum in the meantime, so I can have both. So I guess these are the
because I wonder if there's a way where you shared this PowerPoint and then I shared the Continuum article at the exact same time.
That would be nice, like having two windows.
Yeah, let me see if I can do that on.
Or maybe, maybe I can stop sharing my PowerPoint and still go through it, and you can have the Continuum articles. You see, maybe more comprehensive. How about we do that?
Sure, that sounds great.
Let's do that. There you go. You should be able to share now.
Cool.
There we go.
Awesome. So yeah, I thought this was really interesting because the whole concept of brain death is brain death the same as death. And a really cool thing about this Continuum article is that Dr. Lewis, I love Continuum because I'm an audio person, and they also have a podcast. So I was listening to the podcast that was talking about this article, and they talked about the controversies around, brain death, and that maybe we should be calling it death and not just brain death because it causes confusion with patients and with family members. And I didn't know this, but there are two ways that we can legally define death. One is the one I think everybody's more used to, is the cardiopulmonary death, in which your heart stops and you no longer breathing. But I didn't know that we could also define death from a neurological standpoint outside of the cardiopulmonary arrest. And an interesting thing that she brought up is that we need to come up with a more consensus, because she's arguing that if everyone is using a different guidelines, then there could be, in theory, a patient who is considered dead in one hospital, but if you go to a different hospital, they may be considered alive. So she's stressing the importance, and she says that here. So she was stressing the importance of making sure we use the same guidelines throughout the world so that everybody's on the same page with brain death. And then she also goes in more detail to talk about where this concept of brain death actually came from. And from what I understand, again, I'm not an expert in neuro ICU or brain death, but from what I've understood is that this really started with the advent of the mechanical ventilator, and how since that we started using that in patients, that we could start keeping people alive who were not able to breathe on their own. And because we were able to do that, even though their reflexes were completely gone, they were areflexic from a brainstem and from a cortex standpoint, their heart was still beating and they were still breathing because of the mechanical ventilator. So that's when, and then the idea was, they talked about this in a podcast about organ donor transplant and when is it ethical to harvest organs from an individual, and the surgeons didn't want to. They're like, well, we need to come up with a term so that we all can say, okay, it's appropriate to harvest organisms from this individual only if this individual is quote unquote dead. If they're not dead, then we shouldn't be harvesting organs from the individual. But because there wasn't a clear guidelines as to, well, what do we do with patients who have no brainstem reflexes, but they're mechanically ventilated and their heart is still pumping, is that patient dead, yes or no? So that's when, all these individuals from different institutions started to get together to try and figure out, what are we going to do? So I thought that was pretty interesting in reading and listening to the podcast about that. And so that's when these three different major organizations got together. She has a really cool table that talk about all the different prerequisites for brain death. And one comes from the 2010 American Academy of Neurology. That might be Dr. Let's see, reference 10. Let's see if that's Dr. Davis's paper that they're referencing.
This is really interesting.
Yeah.
We're having.
Yeah, that's it, right?
Yeah.
Nice. So that's their paper that they that she's referencing here.
Yeah, the ethical implications are really, really interesting, and also how it came to be. I think it's around the same time as the first organ donations.
Really?
The first transplant came to be, right? I believe so.
She did talk about like I think the first heart or the first lung was done in South Africa around this time, and then the first maybe kidneys was done between twins, maybe around this time. People shouldn't quote me on that, but she did talk about that in the podcast, or maybe there was. I love listening to a lot of podcasts. So one of the podcasts that I was listening to, they talked about. I believe around this time is when they were starting to do successful organ donations. So yeah, I think you're right.
Yeah, we're gonna have. I'm part of like our local ethics committee, not ethics committee, but we have an ethics program for residents, and we're gonna have 2 discussions about that in December. So maybe if we record the sessions that you're interested in, I can send them over to you, because I'm sure it's gonna be an interesting discussion.
That would be interesting. Yeah, that would be interesting. That really would be. So then the AAN 2010 standard, then they have the 2011 guidelines from the American Academy of Pediatrics, and those are guidelines specific for pediatrics. And then they also have the World Brain Death Project, which I think that one is more global, and it tries to get a consensus guideline from many different governing bodies across the world. And so this table just goes through and talks about what are the differences in each of these guidelines and what are the similarities. So I thought that was a pretty interesting table. And one thing that's a really good table here is table 12.2, where they talk about how to know that a patient is appropriate for a brain death exam. Because I was talking to some of our other colleagues beforehand who were on here before, and one of them said that he's only done one brain death exam, and for the most part, the brain death exam, it varies as to how much is being used across hospitals across the nation. Myself, personally, I have not done a brain death exam. I have heard in situations where brain death exams were requested and were performed, but it's not as common as I thought, as I would have thought as a medical student, but now that I'm practicing. So I thought that was interesting. But some of the things she talks about, when can we do a brain death exam? When is it appropriate? So she has this table here that talks about what are some of the situations that could lead to a false positive of brain death. So a lot of sedative medications. I didn't know this, antibiotics could lead to a false positive in brain death. They also talked about certain kinds of Guillain-Barré can also lead to a false positive for the brain death exam. But I think the biggest thing is these sedative medications. And so I like to do some of these questions. You know how Continuum, they have questions like pre-test questions and post-test questions in the reading?
Yeah.
So there was one question that they had asked about how long do you wait after being given a sedative medication before you can do a brain death exam? And the answer was you want to wait at least 5 half-lives for the medications to clear. And she talked about if a patient is obese or if they have renal or a liver failure, that you want to wait even longer. So I thought that was awesome.
Which especially for some of these can be very long.
Yeah.
Maybe not for your anesthetics. That's interesting.
Yeah.
So it sounds like just going over the criteria here. So we have prerequisites, and then we have a whole bit about the clinical examination, and then we have apnea testing, right?
Mm-hmm.
And then ancillary testing.
Yeah. I'll check this out. So she talks about, for the prerequisites, some of the examples that can lead to a, wait a second. I wonder, are these, some of the mimics that can lead to a brain death exam, but they're not really brain dead, is GBM, botulism, cervical injury, snake bites, and rabies. So that's, I didn't know about that. And so you mentioned some of the prerequisites. A major prerequisite is blood pressure. So I think it looks like the AAN talks about you want a systolic greater than 100 and a mean arterial pressure greater than 60. And I think you want a core body temperature greater than 36.
Mm-hmm.
And what else? You want all these medications to be either not on board or wait for the appropriate half-life before doing the brain death exam. Another thing she brought up was about hypothermia protocol, because some patients, when we get them and they undergo cardiopulmonary arrest or they have an MI, some centers do the hypothermia protocol, and she was talking about that there really isn't a consensus in how long you should wait before you do the brain death exam on a patient who's been rewarmed. In this paper, they recommended waiting at least 24 hours once the patient has reached the core body temperature greater than 36 degrees Celsius. But
you said 24 hours?
Yeah, at least. But she makes the point that there's no evidence-based decision surrounding that. So I thought that was pretty interesting as well.
Yeah. If you want, I can start typing some of these up in our document.
Yeah. Cool.
We go over them. So let's see.
Yeah, I think so. Maybe we should talk first about situations in which we think a brain death exam would be appropriate. Like general, here's,
Mm-hmm. Yeah, I think for someone, I think it goes back to the ICU exam, right? So if they need to be, I think that's where the fundamental difference between brain death and coma comes in, right?
Yeah, because you can have, I think there's different kinds of coma, and there's some coma to where the person can come out of it, but then there gets to a point where your coma is so far advanced that coma, the reason why you're in a comatose state is because you're brain dead. So, and I guess that also kind of goes into prognosis and prognostication. You're in a coma. What's the etiology? And is this etiology so far advanced that now you're brain dead? It's kind of how I understand it. But again, I am a PGY3. I'm not a, like you say, we're learning this together. We're figuring this out together.
Yeah. I think absence of brainstem reflexes is an essential one, right?
Yeah, that makes sense. I wonder if do you think we should share the notes as you're typing?
Yeah, for sure.
Cool. And so what I will do is I will share that, and then we can just be talking out loud while you're typing.
See if I can find some nice graph here.
How can I? Okay, I'm just going to share this. Awesome. So you see the screen?
I can, yeah.
Cool.
So I'm over at my favorite website, EM Crate, as you know, as last time.
I was using that yesterday with the group to finish up our discussion on the neuro ICU exam. I love that website. I'm glad you shared it.
It's really good, isn't it?
Yeah.
So over here, they're saying definition of brain death, irreversible cessation of all cerebral and brainstem functioning, which we of course know. And then, let's see, key findings, they write here. Absence of all cranial nerve function with no pupillary or corneal reflex, no oculocephalic reflex, no cough reflex. And then they write coma as in no response to pain and no brain activity on EEG. And also no respiratory drive. These being the key findings, but that being said, see, and even on the continuum article, on table 12.3, the components of the clinical examination, which I guess is how you define formally the brain death, assessment for unresponsiveness, assessment for absence of motor response to the face and in the extremities, and then again, the pupillary reflex, the oculocephalic reflex, the corneal reflex, and the gagging cough. So you have your, I guess you have your responsiveness, so your level of consciousness, your brain stems, and also like a motor response to the face and the legs and the extremities. So I think that's probably how we define it. Let me pull up something else here. And I wonder what happens if I do something like this. So you're typing there. What happens if I were to do this? It doesn't update automatically.
What are you trying to do?
I typed in something in the brain death exam, but I don't see.
Oh. I think it should show. Maybe it takes a while, or maybe if I go on, continue here, maybe if I go on to here. Oh, so maybe I have to keep refreshing. How about, since you're typing, do you want to share your screen?
Sure.
Okay.
I can. There we go.
Nice.
So yeah, so assessment for unresponsiveness. And then we have absence of all cranial nerve function, and ocular. Just going off of the continuum article too.
Cool. And then while you do that, I can work on copying and pasting the tables into here.
Yeah, so I think these are the main portions of the exam itself. And then the article goes over this other bit that was also mentioned in the continuum, right? The common causes of brain death, right?
Yeah.
So traumatic brain injury, intracranial hemorrhage, anoxic brain injury, severe meningoencephalitis, and cerebral edema from fulminant hepatic failure. And you see how they're talking about what you were saying about the brain death mimics. So, and this would be, so in here, we would be over at the prerequisites, right? So we have the first, I guess the first element of the prerequisites from what we were reading earlier. So we have etiology. Then we have observation period, which, as you said, right, 24 hours if they have if they've been wait, you said 24 hours if they've had like a massive MI and then they were put in a hypothermia protocol, is that correct?
Well, so 24 hours if they've undergone like a hypothermia protocol, and that could be for several reasons. One major reason that I've read is because of myocardial infarction.
Yeah,
is when it's
like the post-cardiac arrest care, right?
Yeah, but it's not evidence-based. It's not like a consistent guideline. That's just what the author recommended, at least 24 hours after the patient has had a core body temperature. So once the patient reaches a body temperature of 36, then you start the clock, because it could take, I don't know how low they go for the hypothermia protocol, but it could take 24 hours for the patient to reach 36. And then you have to wait another full 24 hours at that temperature or greater. Let me pull up the exact wording where she says it. So she says if a clinical exam appears consistent with brain death, it is recommended to delay evaluation for a minimum of 24 hours after rewarming is complete or longer, depending on when the most recent medication that could be used to depress the nervous system was administered. So yeah, that makes sense.
Yeah, and it's also interesting here just looking over how the 2010 criteria kind of differ from the World Brain Death Project exactly with regard to cardiac arrest, and the 24 hours I mentioned within the World brain death project, but I think that regardless of the differences, I think what seems to be pretty consistent here is the fact that they all have the same prerequisites, right? The same list of prerequisites at the very least, right? So I think it's kind of interesting. So they have etiology, observation period, irreversibility, a temperature, a blood pressure, and then excluding intoxications, pharmacologic paralysis, and they have certain laboratory parameters. And I guess etiology is both the differential of brain death and ruling out the mimics, right?
Yeah, and they also mentioned in some of the podcasts I was listening to that if the medical team doesn't know why the patient is in a coma, then it's not appropriate to do the brain death exam. So the etiology of why the person is in a comatose state, there must be good evidence to support, okay, this person's in a comatose state because we're overdosed on narcotics or because of a bacterial meningitis or because of cardiopulmonary arrest. So I thought that was an interesting point to make as well.
Yeah, very interesting. Yeah, so it's required. So in order to call it brain death, we need to require the etiology essentially.
Well, I guess in order to like perform the brain death exam, because we can know the etiology, but the person may not make or fit the criteria for brain death. But before we can even perform a brain death exam appropriately, the team must know why this patient is in a comatose state, or else it makes the brain death exam inaccurate or inappropriate from what I was reading.
It's really interesting.
Yeah.
Yeah, so the main cause is then TBI, ICH, as we said, anoxic brain injury, meningoencephalitis, and cerebral edema. And then the mimics, we went over them. We talked about the drug intoxications, the fulminant, Guillain-Barré, the botulism. If you look here, it's kind of neat that they put an asterisk here saying from these you can have a probable full recovery. You see how hypothermia is also yeah.
Interesting.
Yeah. And then we have the approach. Oh, look, this is neat.
Oh man, this is my new favorite website.
Right?
I love these graphs.
Yeah. So let's see what they have here. Approach to brain death diagnosis. You need a comatose patient. Second step is stabilization and evaluation. So maximum aggressive therapy, complete laboratory neuroimaging evaluation plus minus EEG if needed. If we detect any brain activity, this of course excludes brain death.
Just as complete laboratory plus or minus EEG if needed. Brain death is considered only after complete evaluation with maximum supportive therapy. Yeah.
And going back, speaking of the laboratory parameters, going back to the continuum, they have, at least using the AAN criteria, they have exclude severe electrolyte, acid base, and endocrine disturbance. Because I remember, I don't know if you, I'm sure you've come across this, but I remember as an intern, we had a patient who ended up being severely hypothermic, and we're kind of anchoring on them being septic. Turned out that actually they had a really low, they essentially had an adrenal crisis.
Oh.
Yeah, so you always need to check those like a TSH, ACTH, and they can really cause hypothermia, and I guess in turn produce a picture that's similar to brain death. And then going over the criteria here, you need a complete neurologic exam with no evidence of brain activity. Mechanism of injury, as you mentioned, and then basic neuroimaging consistent with brain.
Because that's interesting, because in the Continuum article, I think in the World Brain Org, or they keep saying that it's a clinical diagnosis. So let's say we have a patient, there wasn't any CT scan done. I know that EEG is not that's more so what do they call it? An additional testing, but it's not needed. So, but I think most places would have already have had a CT head or MRI if they have the capability. But at least from what I read, MRI is not a prerequisite. EEG is not a prerequisite. As long as you know why this patient is comatose, then brain death is a clinical diagnosis. There's even some physicians that went as far to say that brain death is not so much. And I think there's a really good podcast from AAN, separate from the Continuum. Oh, it's called, I think, Neurology Minute. I'll have to find it and put in and send it to you. They were having two physicians that went back and forth. One said it's a clinical diagnosis. The other clinician said no, it's more so a social construct, and that there really isn't we take this clinical picture and we ascribe it to, okay, you have all these abnormalities, you have these clinical findings, and then we just put the term brain death on it. So I've never heard of brain death being a social construct, but let me find I'll send you the podcast. I thought that was an interesting way to put it. So
yeah, I remember reading something ages ago about the fact that some people even thought about introducing the concept of cortical death.
Really?
Yeah, but this is more, like bioethics, like philosophical, I guess.
Interesting. Cortical death. So would that mean that your brainstem reflexes can still be intact, but it's your cortex?
Yeah.
Interesting.
Now, that being said, it's not accepted, it's not something we use, but, and it's kind of interesting because if we look at the Continuum again, right? It's got the 2011 criteria, which are the pediatrics one, right? They say neuroimaging should demonstrate evidence of an acute nervous system injury. Now, the AAN one doesn't mention anything about that.
About neuroimaging.
And the World Brain Death Project is kind of in between and says suggested to ensure neuroimaging evidence of intracranial hypertension is present. But I guess it's not in the AAN criteria. So yeah, it's I thought it would be more yeah, or more univocal, right?
Yeah, you're right. Me too. Me too. Very interesting.
Yeah. And I guess then we look at the confounding factors. If there are no confounding factors, we can move to the apnea test. Now, the apnea test.
I was under the impression, the way I read the Continuum article is that if there, you're right. If there wasn't any confounding factors present, then we don't need the apnea test. Or am I getting confused here? Oh, the apnea test was a confirmatory test. Okay, never mind. So it's like, bracing reflexes are all out. Yes. No confounding factors. No. Then the confirmatory test is the apnea test. Okay. Okay. I talk out loud to make it make sense in my head.
Absolutely. No, it makes sense.
Now it makes sense.
So I guess at this point we're here, right? So we've gotten just trying to simplify that picture over there for us. Let's see.
And while you're typing the notes, I'm inserting some of the pictures from the continuum.
Yes, yes, please.
Cool.
Nope. Nope.
And what you're typing up is so helpful because now I can just print this off, and as I go, see patients, I can say, okay, let me just go through. It's like kind of like my cheat sheet,
Yeah, exactly, exactly. And I just wanted to look over some of the confounding factors here. So unable to perform the apnea test, of course. Unknown intoxication, which I guess though we had ruled out here, right? Because we had excluded the intoxication, so that's good. And then limitations of the neuro exam, like C-spine injury, eye pathology. But otherwise, we can move to the apnea test.
Yeah.
If there are confounders, I guess, a scintigraphy, like a SPECT, I guess, of the brain to check for blood flow.
So here's something interesting is that the different criteria mention what's acceptable for the ancillary testing. So I have to go back and see which one, but they talk about, cardiac or carotid ultrasound versus 4-vessel angiography versus EEG. And I'll pull that up after we're done with this algorithm. So that the ancillary testing, there's no agreement on which ones are valid because each of the different guidelines talks about different ancillary testing for blood flow. Yeah.
I see. Interesting. So I guess let's try to do something else then. Let's see. Why can't I? Because usually here I can enter like a, know how to enter like a box? Because I can't, let's see.
Do you have this document on, do you have OneNote on your computer? Because I know sometimes when you type it up on the web browser, it doesn't show all the, it doesn't show all the functions. Maybe if you go to draw, maybe that's where you can insert a box. Oh yeah, text box.
This one?
No.
It looks a bit different than, nope.
Try.
Let's do this. While I do this on the back end, I'll let you take the helm of the Neuro ICU document and can share your screen.
Cool. I will, let me pull that up.
In the meantime, I'll just work on, because I'm thinking we could, the way I'm starting to think this works is we have our exam, we have our prerequisites math, and then if there are no contraindications to us doing the apnea testing, we do the apnea testing, and that's one thing to focus on. And otherwise, we need to go with our ancillary testing, and that's where, you know, there's not that much, as you were saying, there's not that much agreement between the different criteria, but at least, you know, like big picture, these are the tenets, right? And then, you know, we can, depending on, I guess, our institution and whatnot, we can refine. Although it seems like they all agree on the 4-vessel catheter angiography. They all agree to some extent or another on the EEG and on the radionuclide cerebral blood flow scan. I guess TCDs are in between.
Yeah, that's how I understood it. So let me. Share this.
This would be so helpful, especially because next month I'm going onto night float, which, you know, is the one place where you may,
right,
as you said, rarely be encountered with you know, a brain death exam. So it's gonna be very useful.
Nice. At least you can say that person does not meet the prerequisites, and here's why. Or we gotta wait 5 half-lives, so we'll wait in the morning, into the morning. Let's see. So I can pull up this article. Let's see, I was trying to. Okay, here it is, yeah. So these. Yeah, so it looks like EEG, yeah, like, so I'll add this table to the notes.
Those are the ancillary testing, right?
Mm-hmm. Another interesting thing that I'm glad that they did is they kind of give us phrases that we can say as we're walking patients and their families through this very difficult time, because it is a confusing concept, and Hollywood doesn't help make it any easier to understand. So I like how the author talked about how to, in the beginning, if you feel that a patient may be heading down this route or prognosis is poor, that it's good to just have these conversations early on. And there's one part that she really talked about that was very interesting, where she mentioned, you know, this patient is in a comatose state. You may see movements. All of a sudden, we have another individual coming on. Yay, the more the merrier.
Right.
Hi, how are you?
Welcome.
You're welcome to introduce yourself if you would like.
Hello, everyone. How are you doing? My name is Zaid. I'm a final year medical student at the University of Jordan, and I'm interested in neurology, and I'm planning for the match this year.
Awesome! Congratulations!
Thank you. Thank you.
Welcome to our fun study group. So my name is SEL7 and PGY3 here in the US at Mayo Clinic. And I am going into stroke. I'm applying for a stroke fellowship this upcoming cycle.
That's
Yay.
exciting.
Thanks.
Good luck with that.
Thank you. Jordan, what time is it in Jordan?
It's about 3 in the morning.
3? Oh my,
Wow.
you got dedication.
Yeah, but it's in the middle of my night shift, so I said, why not?
Awesome.
Yep. And I've been in Mayo last September. I've rotated with Dr. Erica Johnson,
Oh,
Dr. Lorraine Previch, and Dr. Monica in the neuro ICU.
yes. Oh my gosh. I know them very well. But I must have missed you because I was here last year.
Are they in your class?
Yeah, Dr. Johnson's in my
awesome.
class.
I really enjoyed it there. I learned a lot of things, and it was really nice.
Wow, fantastic.
Yep, nice to know you all. Thank you.
And I'm Mattia, I'm a PGY2 at MUSC, also in the States, just a bit southern and a bit warmer. Nice to meet you, and best of luck on the match. I know interview season is underway for sure.
Oh yeah, I mean, I finished a couple of interviews and I have like a couple of years off, so a couple of weeks off, and then I'm going to continue my interviews in December and January. So I have time.
Enjoy the Thanksgiving break, because I know those.
Yeah, I should.
Those interviews can be rough, especially if they're back to back.
Oh yeah, definitely. I've seen that. Yeah. Well, nice to meet you all.
You too, and feel free to chime in. We're talking about the brain death exam, and we're using resources. One is the Continuum article, and then we're using another one called EM Crit that I've been recently introduced to, and I love it. I'm sad that I just now found it, but I'm glad that you sent it to me.
All right, great. Sounds good.
Speaking of EM, no, I think this was Palm Crate, but it's all the same website.
Oh.
They just posted this one today is EM Crate, but they just posted a really nice article on acute stroke management, which I was surprised because Casey Albin on Twitter said that this was very advanced. So I'm curious to give it a read when I have a chance.
Ooh, and I think we're going to be talking about stroke management in one of our upcoming sessions. So you can tell us what you think of that resource.
Speaking of strokes, did anyone of you go to the SVIN meeting?
What is that?
The Society of Interventional Neurology that is currently happening.
Oh, it's happening right now?
Yeah.
Oh, that's cool.
Yep.
I don't know enough to go to that meeting yet.
Yeah, there are a couple of researchers from Mayo, I guess.
Oh.
Pranjikchi is one of them. I don't know.
Who?
Dr. Walid Pranjikchi.
Oh.
I don't know how to pronounce his name, but he's one of the good interventional neurologists or radiologists.
Nice. Well, we're going to be having the stroke. I think that should be coming up. Let me look at the calendar, see when that's coming up.
Is it on Monday? I think it may be on Monday.
So it's Saturday. Maybe we may do it Saturday, Sunday, depending on how far we get. So feel free to, if you hear anything great that from the conference, or feel free to chime in. This is very informal. We're all just come together and we're all just, help each other learn the topic. And I'm no expert in any of these areas. I'm just learning along with everybody else. Just want to create the space where we can all come together and learn. So I'm glad that you're here. And this has been this is like an international study group, which is even more awesome.
Yeah, it is. Thank you so much. And I'm sorry for the interruption.
No, don't be sorry. People have been coming in and out since I've been on. So that's how I like it,
And just the dedication to call during your night shift, that's major at 3 in the morning.
Yeah, it's like 20 minutes break. So I've always wanted to join one of these study groups.
Yeah.
So I had time now. I hope to be
Yay.
able to join them in the future. Yeah, thank you.
Awesome. So let's see, where were we? We're talking about the apnea test or the different ancillary testing.
Yep. And I am done with my little graph that I developed. Let's see if it's actually accurate. I'm gonna just post it there and you let me know if
Cool.
we've got to a good point, and then we can go ahead and chat about I guess the ancillary testing and the apnea testing. Can you see it?
Let me.
Should be.
Oh, you just made this?
Yep.
Wow, that is awesome. You can share your screen if you want. That is so cool.
So let's see. By the way, I've been on Zoom all day long because there's an epilepsy conference that I'm seeing. So I've been on Zoom all day, but
Nice.
still for some reason I'm not able to share my screen. Not getting any savvier. Let's see. View copy. Oh, there we go. Okay. There we go. So I think,
Nice.
are we right about this? So prerequisites math, then we do an exam that's consistent with brain death, and which are these criteria here, right? And then from there, we wonder if we can perform safely and interpret the apnea testing. If we can, go ahead and do apnea testing. Otherwise, we have ancillary testing, right?
Perfect. That makes perfect sense. Yeah. Nice work.
Good.
Awesome.
And then we have the apnea testing itself. What have you read about the apnea testing before I came on?
What was the question?
Oh no, what have we what had you read about the apnea testing? Any pearls that you have?
So I was trying to figure out how to actually perform, and I was trying to look up videos that talk about how it's performed. From what I understand is you pre-oxygenate the patient first, and then you shut off the vent, let them reach elevated CO2, and if they're, what's the receptors called? If they're
The bioreceptors and what's the other one?
if some kind of receptor gets triggered when you have high CO2, then that's supposed to kick the brainstem to want to breathe. But if your brainstem is shot, then you don't have that reflex, and so you're not breathing, then you become apneic. That's how
Are
I
they
read.
the chemoreceptors?
Yes, exactly. Yes, the chemoreceptors.
Mhm.
So that's my very elementary understanding of the apneic testing. But let me look for a video that I could show. We can all learn it together.
Yeah, I was wondering, you know how Continuum usually has a nice video gallery? I wonder if they have something for this article. Did you check it out already?
I didn't see that they did. Let's see. Apneic.
Let's see, maybe under media they have something.
I found one that looks legit, so let me share my screen. If you guys find a better resource, I'll stop sharing my screen.
Examination by Dr. Robert Tasker.
Can you guys hear the volume?
Mhm.
Yep.
At this stage, we would now want to do the apnea test, under normal circumstances, the child would have had their mechanical ventilation altered, so the carbon dioxide was at around 40 millimeters of mercury, and we would have pre-oxygenated for at least 10 minutes with 100% oxygen via the ventilator, and have a blood gas to show that our carbon dioxide was around 40 millimeters of mercury. We then proceed to the apnea test, and there are a couple of ways of doing this. We need to have the child's chest exposed so that we can actually see any breathing movements, and then we want to try and maintain oxygenation during the procedure. After disconnecting the child from the ventilator, we can use a T-piece connected to the ventilator with at least 10 liters per minute flow through that. When we disconnect the child, we're then going to make sure that the oxygen saturation stays above 85% and that the blood pressure stays above the 5th percentile for age. And in this child, we'll take it to be 75 millimeters of mercury. And we need to observe the child for a period of 5 to 10 minutes. And during that time, we would hope that the carbon dioxide would rise by at least 20 millimeters of mercury.
Please note, if the oxygen saturation falls below 85% or the blood pressure falls below the previously determined lower limit, the test should be discontinued. Before reconnecting the child to the ventilator, a blood gas should be drawn. If the results of the blood gas analysis demonstrate a PaCO2 level greater than 60 millimeters mercury, then the apnea test would be considered positive. Therefore, this apnea test does not need to be repeated. But if this was the first apnea test, you would still proceed with your second clinical and second apnea test.
In this instance, let's just assume that we've not seen any breathing for 5 to 10 minutes. At the termination of the test, we would take another blood gas, connect the child up back to the ventilator, and wait for the result of the gas. If that showed a 20 millimeter rise, and it was above 60 millimeters of mercury, then we can say that the child has not breathed to that stimulus.
Point of clarification. Please note, the apnea test should be performed following both brain death examinations. Clinical pearl. Please note, brain death should never be diagnosed at a PaCO2 level less than 60 millimeters mercury, even if the rise in PaCO2 has been 20 millimeters mercury or more. There have been case reports in the literature of children breathing at higher PaCO2 levels. Therefore, some experts have advocated that the threshold should be raised even higher than a PaCO2 level of 60 millimeters mercury. You will need to follow the guidelines set forth in your institution. Please also note, any breathing, no matter how high the PaCO2 level, indicates that the diagnosis of brain death cannot be made.
So something when I was reading, so they make mention to apnea testing. So the criteria for brain death in pediatrics, unlike in adults, it requires, I think, 2 clinicians to perform the brain death exam versus in adults, you only need 1. So that's an interesting difference between the consensus guidelines.
So basically, you pre-oxygenate for 10 minutes at 100% oxygen, right? And then after that, you just stop the vent essentially. You reduce the ventilator frequency, and then you finally disconnect the ventilator, and you want to make sure that the PaO2 the SaO2 actually doesn't drop below 85%. In the meantime, you're waiting for your PaO2 to ramp up, PaCO2, sorry, to ramp up to 60. Okay.
But
And
I
then
do
you
think
check-
it might be hospital dependent, because when I was reading the Continuum article, I'm looking at it now to see, let's see what they say. So they don't really give like specifics like this video does. It just says you pre-oxygenate. Doesn't say for how long. It does say you want to avoid hypoxia by placing a catheter that is less than 70% of the ET tube diameter. And you want to deliver up to 6 liters per minute of oxygen to avoid pneumothorax. You can also use CPAP if needed. But they don't give a specific, you have to pre-oxygenate for 10 minutes, at least here in this article. But then after you pre-oxygenate, then the AAN says you want to reach a target of PaCO2 greater than 60, or unlike that video for the peds, it says or greater than 20 millimeters of mercury above baseline. But then, but according to the American, according to the pediatrics guideline, let me just show you guys this so that I think I'm a visual learner, so let me just show you. Okay, so it says here, this is where I'm reading.
Yeah, the 20 millimeters of mercury is a really good point, especially with all our COPDers, right?
Yep. Right. And then this here is where it just says you just want to pre-oxygenate. And then you're right. Is it Zaid? You talked about the medullary chemoreceptors.
Yep.
Good job, Zaid.
Thank you.
In the setting of hypercot or elevated CO2 and acidosis. So we pre-oxygenate for some period of time, probably depends on the hospital protocol. And then you can pre-oxygenate with supplements with nasal cannula or some oxygen tube through the ET tube or CPAP. Then, what point do you disconnect from the vent? After you pre-oxygenate, then you disconnect it from the vent? And then take serial blood gases?
So if you look over the table, the 12.4 table, so it says, so we've got the pre-oxygenation step. And then you check your PaCO2. Okay. And they all agree about this step. And then, so using the AN criteria, you reduce the ventilator frequency first. Then you reduce the PEEP to 5. And then you disconnect the ventilator. So you're decreasing the tidal volume first.
I see.
And then the pressure.
Oh, so it does give a specific time. Okay. For at least 10 minutes. Okay, cool.
And then you preserve oxygenation with an insufflation catheter through the ET tube.
Okay. And then now the question is, do you just, if you just get a value of greater than 60 for PaCO2, then it's positive a positive apnea test?
Yeah, I think you've reached the target, and then at that point, if they're not taking any breaths, then you're done.
Okay.
Right?
Yeah, that makes sense.
Okay.
Then let's see.
Nice if someone made a flow chart of this. Would be nice if someone made a checklist or flow chart for the apnea testing.
We should ask Gabriella. I'm sure she's with all of her beautiful diagrams and flow charts. Maybe, but yeah. No, but I think the one you're making is great.
There you go. So apnea testing, if no respiratory drive is observed, repeat ABG after 10 minutes. If respiratory movements are absent and arterial and PaCO2 is over 60 millimeters of mercury or the 20 over the baseline, the apnea test is positive. Okay. And then I think finally they have a bit about reasons to abort testing, and if its systolic is lower than 90, and if oxygen saturation is lower than 85% for more than 30 seconds.
Yeah, that makes, with less than 90 makes sense. Now I'm going to be intentional. Next time that there's a brain death exam being performed, I'm going to go seek it out because we don't do many. Oh, I guess we can talk about that at the end. And what situations, have we seen a brain death exam being performed? Because, well, I won't digress, but that'll be a good conversation to have near the end once we're done with getting through everything.
I agree. And I also thought, speaking of that, you said something about the phrases that they have here. And I think that's something brilliant to kind of, I think I'm gonna print that page and maybe laminate those phrases, because it's kind of good to have with you, especially in the middle of the night, if you get called to something like this, at least to have a standardized way of dealing with this, right? And of helping. I mean, because family must be very much traumatized by all of this, it's good to have a good way of explaining things without, unnecessarily traumatizing people further.
That's a really great idea. So I'm going to share this, and then we can kind of recap some things.
I think.
So, go ahead.
No, and I was going to say, and I think the additional thing would be ancillary testing, just to review those points that we were talking about before.
Oh, yeah. So then let's see. So then basically this table here, let me see if I can screenshot this. Give me 1 second. Zaid, have you ever performed a brain death exam or seen it? I'm just curious, done before?
Yeah, well, my first neuro ICU experience at Mayo, it was with Dr. Barsek. And yeah, she's a very nice specialist. And we had this patient who was from overseas, and he was post neurosurgery. And he was in the ICU for 2 weeks. And then he suddenly went into cardiac arrest with no reason for that. And we did not, he was brain dead by diagnosis, but we did not document that because he's legally dead, and we had to remove the ventilation and all that stuff. But the family wanted him to go back to his home country. So it was like a nice experience. It was so sad for the family. We did not do the ancillary test. We did the brainstem in general, and I guess it was the carina reflex, something like that. It was like the gag, something like that. But we did not perform anything further than that. So I do a bit of that, but not the advanced stuff.
Interesting. Yeah, I haven't seen one done in person, so I'll have to be more what's what I'm looking for? Intentional about, because it's not performed often. I think it's only performed in.
This was the first time seeing the pupils non-reactive, like they're just blown non-reactive.
Wow. So here for the ancillary testing, here's just a section from the Continuum article that talks about each references acceptable testing. So the AAN 2010 guidelines, the 4-vessel catheter angiography, which I've never seen that. I didn't know that existed. I'm gonna look that up. And I'm looking it up right now. 4-vessel. Biggest. Oh, so it's not anything, they just stick it in what, all the extremities? Or what? Anybody know?
I'm kind of wondering if they're just talking about the regular angio and the 4 vessels would be like the ICAs and the Aborts. But that's such a weird way of describing it. If
Yeah.
that, right? Because I guess I always called it angio.
Yeah.
I guess that's it. I guess we do have 4 vessels that go to the brain, but they never. It confused
Yeah.
me. Confused me too. And then the second, I'm like, oh wait, are they just talking about the irregular angio?
Oh, you're right. Yeah, just a regular angio. CT, head and neck can be used to look at the veins of the 4 arteries, 4 vessel study. Huh, there you go.
Yeah, I guess that's what's called.
Oh, now I want to be like, I want a 4 vessel 4 vessel angiogram, please. They'd be like, what?
Next time you have to do you have to send someone for mechanical thrombectomy, you can call it a 4 vessel angio.
Awesome. So then that's
So sorry,
the
guys. Sorry for the interruption. I have to go. My break is over, but I will definitely join you in the future meetings. And this is an awesome idea. So thank you for that. It was nice meeting you.
you
Nice to
too.
have you.
Thanks for coming.
Thank you. Thank you. See you. Bye bye.
Get some
Bye.
rest. Take care.
That is so cool.
All the way from Jordan.
Yeah, there's people who signed up from Cameroon, Germany, Spain, Brazil, Middle East, all over the world. So it's been pretty cool getting to know
would you-
people.
Are we just missing
then also-
Australia from the list?
Yeah, I haven't seen someone from Australia sign up yet, but I'm sure. Now that's my goal, is to find someone from Australia and recruit them to sign up. Cool. So with ancillary testing, so this article talks about in what situations ancillary testing is appropriate. So let me pull up my notes again. And while I look that up, a question that was asked in one of the readings, post-test reading, was, is consent needed from the family to perform a brain death exam? And according to the AAN guideline, consent is not needed. But that the author of this paper does emphasize, obviously, try and talk with family and explain to them, what tests you're performing and maneuvers and why it's important, and trying to get everyone on the same page. So situations where we need ancillary testing is if medication effect is present, or if it felt that it would help the family members better understand the diagnosis. Other situations in which we're uncertain about drug elimination, or there's severe laboratory derangements that cannot be corrected. So yeah, and then the purpose of ancillary testing is to evaluate for loss of cerebral blood flow or brain activity. And some of the testing that can be done is EEG, evoked potentials for CT head and neck, CT perfusion studies, ultrasounds. And here's a point that the authors emphasize, is that brain death is a clinical diagnosis or clinical evaluation. And then they just go and talk about the different societies and which ancillary testings they accept. So yeah.
Yeah,
And
it's
then the
interesting that
last-
they mention. It's interesting that they mentioned the point about ancillary testing in case it helps family members understand the diagnosis better. I think that's a very, very important point.
No, yeah, I completely agree. Let's see. And then here, so ECMO, I'm still trying to understand this whole ECMO point, but it sounds like the prerequisites don't change. And there was a question that was asked in the post-test that talks about, how do you perform the brain death exam on a patient who is on ECMO? And the answer was you get an expert to kind of help you perform, the apnea testing, because it can be, complicated. It's pretty much what I got out of this section is nothing changes, and get a cardiologist to help manage the ECMO while you perform the brain death exam.
Out of safety, I'm assuming, right? Is that?
Yeah. And then another point, and then she goes on to talk about hypothermia. And the big thing is we talked about this earlier, you want to wait 24 hours after rewarm is complete, at least. And then we talked about this too, you want to wait at least 5 half-lives for adequate medication clearance. And then here she talks about communicating brain death to the family. And I like how she uses the metaphor of brain death is similar to loss of heart and lung function, and that their brain death is the point of no return, and then it's irreversible. And then it's only a matter of time before the heart will also go into cardiopulmonary arrest. So yeah, so those are the big points.
I think that's a great point, especially because I know people who would say, well, my brain is dead, but the rest of the body is still working, so I'm not dead, right? Which is something we're talking about before. I think it's can be a very confusing concept for people who are not in the medical field. So.
Oh, and I wanted to share with you because I love podcasts, and so I was listening to. Do you like podcasts as well? I love.
Oh podcasts. Yeah. We could spend 2 hours just talking about the podcast. I feel like to you and I.
I know, right? There's I think, let me find my phone so I can send you the link to the 2 podcasts I was listening to that talks about brain death. I love brainwaves, even though brainwaves is no longer producing.
That was the best. That was the best. That was the radio lab of neurology.
Oh, I love it. So well done. I'm so sad that it stopped, but I get it. It probably takes a lot of work. But I was listening to so they have 2 episodes. I'm going to pull it up and show you the screen. Brain waves.
By the way, while you do that, I have added one really cool table, or tried to, that I found in one of the papers about brain death, and it's got a nice checklist. Let's see if I can share my screen.
Nice.
I'll just show you. So this one here, do you see? So checklist for determination of brain death.
Oh, beautiful.
It could be nice to just carry around,
I agree. Yeah, that is awesome. That is awesome.
Yeah.
Oh, that would be very helpful.
Okay, let me stop sharing.
And so here's this screen. So brain waves, they did episode 81, brain death part 1, social construct. So this is where one of the physicians talks about brain death not being a clinical diagnosis, but a social construct. So I thought that was pretty cool. And then they also do, after this one, they also have part 2, which is episode 82. Let me just. Is it gonna be? Let me just say 82. Yeah, limit brain death part 2. So this one was pretty cool as well. And the references that we talked about, they also reference as well. So I thought those are 2 podcasts that I really enjoy. And I think that there's another podcast that I was listening to on brain death that was interesting. And I'll put this in the OneNote so that you have access to the link. I think, what was it? Neurology, the one from AAN, I think they also do one on brain death. Let me find it.
The neurology podcast.
Yeah, what do they call again? Neurology Minutes?
There's the neurology podcast, and then there's the neurology minute. I'll be right back.
Okay, cool. I'm just listing these links at the bottom. And then here's another interesting podcast I was listening to on brain death it's called Anatomy for Emergency Medicine.
Huh, never heard of it.
No, that one's for brain herniation. Never mind, I'm gonna hit myself. That one's for tomorrow. Oh, it's called Clinical Cases in Neurology. Let me type that in. Nope. I'm also getting my head of myself. Never mind. That is brain herniation. Oh, that's for tomorrow. Never mind. I think those were just these were the main 2 ones.
I didn't think I know that podcast. What's it called again?
Oh, which one? So what I do, do you have an Apple phone?
Yeah.
So what I do is, where did this go? If you go to, I can show you this. Can you see my phone? Oops.
Yeah, kind of. Not really.
Probably because of the lighting. So I have the podcast app, and then if you just type in brain herniation, it'll search the entire Apple podcast for any episode that talks about brain herniation or any episode that talks about brain death exam. And that's how I select the podcast that I listen to. So that's how I find the different podcasts that I subscribe to.
Did they do a AAN neurology rewind on the brain death exam? Do you know?
I feel like they did, and that's what I was trying to look for. Let me look it up. We can look it up together. Oh, yeah. So they did one in January 2019 issue. Let me type that in.
Because that's another podcast I really enjoy, the AAN Rewind.
Oh, yeah.
Start of the month.
They're really good. Yeah, so is it this? Yeah, brain death, yeah, remember. Are you talking about this one?
Let's see.
Let me play it.
Thanks for tuning in for the January 20. This morning, I had the pleasure to be speaking with Dr. Jim Russell, who's a neurologist at Lake.
I guess they didn't do a proper rewind.
Oh. Huh, let's look it up. Brain death. Brain death exam. So you're looking for the rewind. Oh. Maybe it's the January 2011 one. If you find it or you come across it, let me know. Or put it in the.
But I'll definitely listen to the brainwaves one.
Oh, hold on. Now I can't hear you.
Hear
My
me now?
computer likes to act funny. Sorry, say that again.
No, I was saying I'm
man.
definitely looking forward to listening to the.
Can you hear me?
Yeah, can you hear me?
Oh, my computer. Oh, let's see.
Can you hear me now?
Can you hear me now?
Yeah.
Great.
Great.
No, I was saying I'm definitely looking forward to listening to the brainwaves one.
Yeah. Tell me what you think.
Mm-hmm.
Especially in the social construct and given your like your experience with the ethics committee.
Yeah,
Right,
I think those two will be at the start of December, so I'll definitely let you know.
Cool.
Alrighty. Have we gotten to a good stopping point for the brain death? Anything that we haven't touched upon?
No, I think we covered it all.
Very good.
And then what I'll do, I'll figure out a way to start archiving these notes so that for people who weren't able to make it, they can, review the notes, and then I'll post this on YouTube, and all the links will be on my website somehow. But thanks for joining, and thanks for typing, and thanks for embracing this study group. It's always fun to have other people.
My pleasure. Thanks for organizing.
Of course. Of course.
What's the topic tomorrow? Remind me. Herniations?
Let's look. I think the topic tomorrow is, so we finished, it's going to be coma and brain herniation syndromes. And there's some really good podcasts on brain herniation syndromes. I'll tweet it to you on Twitter.
Wonderful. Looking forward.
Cool.
As I told you, I'm going in and out because I am also at the virtual conference, so I'll try to come in as much as I can.
Oh, cool. No, enjoy the conference. Conference comes and goes. We can always redo, brain herniation again. So no, don't stress out about this.
All righty. My pleasure, though. Have a good evening, okay?
You too.
All right. Bye-bye.
Bye.